My GP cut me from 3 tablets a day to none in 3 weeks. Says the new rules left him with no choice. That single sentence from a farmer in rural Queensland captures the tension behind today's opioid debate. 1 decade, we were told strong pain medicines were the answer. The next, we were told they were a problem. Australia didn't just follow the United States. We copied almost step by step, racing from enthusiastic over-prescribing to an equally abrupt clampdown. The very experts and policymakers who champion opioids are now backtracking at speed and risk being just as wrong in the opposite direction. In this episode, we'll trace that swing from one extreme to the other and ask what a sensible middle road looks like. Stay with me and you'll hear, briefly but clearly, how the miracle pill story took hold and why scripts tripled in the dozen years. What the rapid crackdown really looks like for doctors and patients on the ground. Where the numbers hide the pain. Policy wins that impress the spreadsheet but yet leave people in withdrawal. Practical steps any clinician, patient, or policymaker can take to replace knee-jerk swings with balanced, evidence-based care. By the end, you will have a framework to judge whether falling prescription charts truly mean safer communities or just another crisis wearing a new mask. How we got here. In the early 2000s, long-acting oxycodone landed with glowing American studies and even glossier marketing slides. Safe, low addiction risk, perfect for chronic pain. Our guidelines echoed the message. Prescriptions tripled by 2013, especially in regional towns short on alternative pain care. But fatal overdoses climbed with them, almost traced to pharmacy bottles, not street drugs. Then the sudden clampdown. By 2018, policymakers hit the brakes hard. Over-the-counter codeine was upscheduled to prescription only, so consumers could no longer obtain what many saw as safe and appropriate pain relief straight from the shelf. At the same time, the screws tightened on prescribers. Schedule 8 approvals became tougher. Every high-dose script lit up, safe script with red flag alerts, and doctors were warned that exceeding soft morphine equivalent thresholds could trigger an audit or medical board review. In other words, patients lost reliable access while GPs and doctors were made to feel that writing an opioid prescription was almost a criminal act. PBS pack sizes shrank, automatic repeats disappeared, and a 12-week taper rule arrived for chronic, non-cancer pain. Subsidized opioid supply fell about 20% in a single year. On paper, the crisis looked fixed. We have seen this storyline before in the United States. Prescription opioid use there roughly quadrupled between the late 1990s and mid-2010s under the rallying cry, "Pain is the fifth vital sign." The pendulum then swung hard in 2016 when the CDC guideline was widely read as imposing rigid dose thresholds and fast taper targets. Some clinicians discharged long-term patients, withdrawal admissions spiked, and in 2019 the FDA warned that abrupt cuts can be lethal. By 2022, the CDC had revised its stance. scraping fixed numbers, stressing gradual patient-centered tapers, coinciding with the federal efforts to expand access to naloxone, physiotherapy, cognitive behavioral therapy. Overdose deaths are finally starting to plateau, but only after a costly lesson. Blunt policy makes dashboards look better first. Patients feel the pain later. Australia now stands at the same crossroads. A policy win on paper isn't always a win in real life. That tidy, neat spreadsheet victory didn't match clinical reality. Some long-term users were tapered in weeks, not months, and suddenly found themselves managing withdrawal instead of pain. Rural patients discovered the only GP willing to handle Schedule 8 scripts might be a 3-hour drive away. Meanwhile, private scripts, including those written through fast turnaround telehealth services such as instant scripts, were sharply rising. The private share of opioid dispensings doubled between 2013 and 2022. So much so, in 2023, the Medical Board and the TGA issued infringement notices and new guidelines targeting unsafe online prescribing of high-risk Schedule 8 medicines, underscoring the problem. Counterfeit tablets were detected on the streets. Doctors face a dilemma to adhere to a rigid paper policy or meet the needs of the person in front of them, or risk audit scrutiny. The numbers improved, the human stories did not. Finding the middle ground. The Royal College of General Practitioners, GPs, and the College of Pain Medicine now emphasize individual taper plans rather than fixed one-size-fits-all dose ceilings. Pain Australia and several primary health networks are lobbying for new Medicare benefit schedule items that bundle physiotherapy, cognitive behavioral therapy, and pharmacist review because those cuts without funded alternatives leave patients stranded. Naloxone nasal spray is supplied free of charge at participating pharmacies and health services under the National Take-Home Naloxone program. No prescription, but you do have to ask at the counter. Restrictions alone aren't reform. They need education and sustained funding behind them. Some practical recommendations for clinicians. Treat the real-time prescription monitoring alerts as conversation starters, not hammers. Document function as well as pain scores and pair any taper with a written rehabilitation plan, physiotherapy under a chronic disease management referral, psychology sessions, and pacing strategies. For patients and carers, don't attempt a sudden dose cut on your own. Ask your doctor for an individual taper schedule and a plan that unlocks subsidized allied health visits. Keep naloxone at hand if opioids remain part of care. And for policy makers, dashboards don't feel pain. Extend take-home naloxone funding program beyond June 2026. Raise Medicare rebates for multidisciplinary pain care. Make sure safety doesn't come at the cost of compassion. Australia had to curb opioid overuse, no argument. The challenge now is ensuring the pendulum doesn't overshoot and strand legitimate pain patients. Next time you see a headline celebrating falling prescription numbers, ask, are we also counting withdrawals, long drives for scripts, and the black market pills, and patient pain, real patient suffering? Thanks for listening and for thinking critically about where safety and compassion truly intersect.